The broadcast is now starting. All attendees are in listen-only mode.
Welcome to another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover understanding ICD-10 integration and tools. We're joined today by Wyn Staheli, the Chief Content Officer of FindACode.com. Wyn is a frequently sought-out subject matter expert on coding in ICD-10, and we are excited to share her expertise with you today. Before we begin, some quick notes for our attendees. If you have questions during this session, please enter them into the chat area during the presentation. In the second half of our presentation, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent by email link later in the week. Also, note that all registered attendees of today's session will receive an email with links to both the recorded and PDF versions of this event. Well, thank you for joining us today, Wyn.
Well, thank you for having me.
Let's begin. So, to begin, why do we even use codes?
Well, there are many reasons why a standardized coding system is necessary for all healthcare. Generally, this standardization helps everyone work together. We have a coordinated effort in promoting quality care. So, in no particular order, we'll start off with being able to identify fraudulent data. Yes, I know we all hate to admit it, but there are a few bad apples in our crop of healthcare providers. Using these standardized code sets helps us and all the different payers be able to weed out those who are using the system incorrectly. This helps us keep our high level of professionalism by getting rid of those who aren't using the system correctly. It also helps to keep costs where they really should be. The second reason is being supportive of medical necessity. We all know that medical necessity is the main criteria that payers are using. We need to be able to support the procedures and the diagnoses, and so using standardized codes helps everyone to stay on the same page. Another reason is for research and clinical trials. We all need to know what works, what doesn't work, and this also ties into that last one of measuring quality and efficacy of care. We need to be able to figure out how to provide the best care for the entire healthcare population. We have to be able to use these codes in order to figure out which things are working, which ones aren't, and move forward from there. Another is being able to set health policy. There are many treatments out there that just don't promote or meet what is being promoted. So this helps carriers and other third-party payers be able to establish appropriate policies. And of course, the obvious one that we all know is being able to process claims for reimbursement. We all need to be paid. And this standardization helps everyone to be paid for technically the same service. Everyone should be paid the same rate.
All right, so that's the reasons for standardization, but why is it important now for us to move beyond ICD-9 to ICD-10?
Well, ICD was originally developed by WHO, that's the World Health Organization, and it was for public health and statistical analysis. Basically, they were trying to track disease trends, where were outbreaks happening, what were the main causes of death. And so that was the original purpose of the development. Now, in the United States, we created a clinical modification. And this is our own unique interpretation of the original ICD-9 code set. We began this back in 1979. That was a very long time ago. Now, because we've been using it for so long, we're starting to run into limitations. And it's just because it's been used so much, we're running out of sections. We can't fill in codes. We've hit our limitation in sections or in code numbers. And if you tune into some of the coordination and maintenance meetings, you can see and hear some of the challenges of where you can place some of these new diagnoses because they don't really fit into some of the current categories. So we're not capturing current knowledge and technology. We're trying to work it into old technology. So we're not even being able to meet the future needs and moving further into this new century. The other reason is that there's a lot of reliance on paper documentation. And we all know paper documentation, and when we have to justify clinical necessity, we have to send our supporting documentation because there's so many of these unspecific codes. So payers need to understand what really happened, so we need to send that paper documentation. This slows the whole payment process and just bogs the whole system down. So we're trying to keep things moving and moving forward. Another reason is the ability to compare costs and the outcomes. This old system really makes it difficult, especially as we're relying on paper documentation. You can't really do trend analysis and such statistical analysis as we really need to keep moving forward.
So if I understand it correctly, part of the problem is that the codes are no longer able to keep up with the diagnoses, and so then the paper documentation sort of fills in that gap, and that causes a lot of problems. Is that one way of summarizing it?
That's one way of summarizing it. It goes beyond that too. Is just
right.
The paper there is helping, but it's more than just that. There's so many changes in the way that we provide health care compared to the way we did it clear back in 1979. It's just a different methodology of rendering treatment, and the code set just is not letting us keep moving forward.
So tell us a little bit about ICD-10 then. What's its history?
Well, ICD-10 was originally introduced by the CDC, the Centers for Disease Control, clear back in 1990. And they worked with the WHO, and most of the industrialized nations are already using ICD-10. The United States are like the last holdouts. We're just kind of holding up the whole show. The difficulty that this seems to present is that when we're trying to compare data of disease trends and things like that, we're speaking a different language than the rest of the world. Our next reason is, our next piece of information is that there are about 68,000 diagnosis codes. As we did this clinical modification for use within the United States, we've been able to expand it to address some of those problem areas where we know we need to do better and to code better to avoid some of the known problems. So it does increase the number of codes dramatically. Now, as for the date of implementation, this seems to be the point where everybody is getting holdouts, those that think that it's not going to happen. We know that the official date is October 1st, 2014. And CMS is very, very forward-thinking, and they've been right on track. They are reiterating that their federal programs, all of them, Medicare, Medicaid, they are on track to meet that October 1st deadline. And I constantly get email reminders that providers who are hoping for another delay, I think the fact that there was a one-year delay before has caused issues, and providers are hoping for another year delay, and there are some people who are trying to avoid it entirely. However, CMS is moving full steam ahead for that October 2014 deadline. So we need to be careful. If CMS is requiring ICD-10, if you're not using them, if providers are not using them on that deadline, then their claims will be rejected. And we all want to be paid, so we need to be ready.
And people should not expect another delay. So why is it
not according to what CMS has been saying? They need to be very, very careful. Don't plan on a delay. Plan on implementation going forward as it should be so that we're prepared.
So why is understanding anatomy important with ICD-10? I guess this gets into some of the complexity of the ICD-10.
It's very, very true. One thing that we need to, it's a different way of thinking. Now, when we compare ICD-9 codes to ICD-10, and you look at crosswalks or mappings that are out there, it is not always a simple one-to-one. For instance, you used code A, now you use code B. Sometimes there are situations where you use code A, now you'll be using code B and C. The problem that we have encountered is that those simple one-to-one and one-to-two mappings, or one to a couple of mappings, aren't where people are going to run into issues. And so the anatomy comes into play in those cases where there are one to multiple codes. Now, here's a worst-case example. These are some significant ones. If you look at code 733.82, which is other disorders of the bone and cartilage, non-union of fracture. That is in ICD-10. When you look at the crosswalk and the mapping, that particular code maps to two codes in the S02 series, and S is the ICD-10 injuries category. In S12, there are 14 codes, and in the S42 category, there's 3 codes. Now, as you keep going through a mapping, you will find that just that one single code maps to 2,530 ICD-10 codes. So there is a significant difference, and the reason is because we are more specific as to actual location. That is why anatomy and fully understanding anatomy plays a much bigger role in ICD-10.
That's interesting. So when it comes to implementing ICD-10, what are some of the questions that providers should ask themselves to assess whether they're ready?
The very first thing is you need to start poking around. What do you already know about ICD-10? Have you looked at any of the codes? Have you looked at what impacts you will have? See what the differences will be on those things that you're used to using now in ICD-9 and looking at ICD-10 and how those will be changing. Different specialties will have different requirements and different changes. Why are we changing? Sit down and look at the reasons of why we need to change, and that will help you embrace joining and making the changes. If you feel that this is just a waste of your time, it will make the process more difficult. Another question you need to ask yourself is, how much will this change affect our clinic? Look at your clinic practices. What things need to be modified as you look at what needs to be changed, and get everybody in your clinic involved so that everyone is all on the same page. Another question to ask is there anything that's concerning us? As you start to look at those problem areas and get everyone on the staff involved in coming up with good solutions to specific issues that regard ICD-10 implementation. Some specific questions you need to look at are, well, what are some of these problems that we've run across with payers, and look and see if ICD-10 will resolve some of those problems. For instance, the non-specific codes that you've been required to have additional documentation, a lot of those are addressed in ICD-10, and so look at your problem areas and see if you can get some of those resolved simply by adopting ICD-10. You need to sit down and also look finally where you need to go so that you get information and you get the education and be prepared.
So before we continue, we've had a couple of our registrants ask about the slide deck and its availability. So I just want to remind everyone that we will send out a follow-up email that will include a copy of the slides, so you'll be able to review them later. So what are questions providers should ask their software vendors about the switchover?
One thing that we've encountered in speaking with providers is a lot of them just simply assume that their vendors are going to be ready. You can't assume that they will be. You need to take the time to carefully assess each of your software vendors and find out and determine what their ICD-10 readiness really is. So some of the important questions that you need to ask are, what implementation plans and timelines do they have in place? You need to be aware that there has to be sufficient time to test carefully and thoroughly before the deadline. Those of you who've run into some problems with the 5010 implementation can attest to the fact that it's important to have sufficient time to test. Another thing that you need to check that isn't on this list is your current contracts. I would make sure that you review your current contracts and review specifically what each payer says about ICD-10 implementation. You need to also carefully look at anything that's changing in your contracts, because you will need to be renewing contracts, and very carefully renew those contracts to make sure that other things haven't changed that you're not really entirely aware of. Things like some of the other requirements that they may be having for example, electronic payment. So they may be requiring everything to be paid electronically. So very carefully renew your contract. When you're renewing your contracts, double check that information. Another question you need to ask is what software changes will be needed. Some software is already ready to go, and they've done testing and they're already prepared, so you may already have the upgrades. So you need to double check, don't assume, double check and ask them if you need to make changes, if you need to upgrade something. You may need to upgrade hardware to handle some of the new system requirements. Another question you need to ask is what products and services will be available once this implementation takes place. There may be some products that they are doing now which they will no longer be doing when ICD-10 is implemented. So if you are subscribing to more than one particular service, ask about each one individually. Don't assume that everything will be transferred over. Another question to ask is ask them when they'll be ready for you to practice and test. Ask them when you can use your real data and start that testing so that you have that part of your timeline for implementation in your practice. Another question is to ask them what guidance or assistance they will be providing during the rollout. What happens when during testing you run into problems? Will you need to be working with them directly? What kind of support will be offered? Will you need to look at the different support contracts that will be available? Will they be doing training? Some of them actually, I've noticed, some vendors are providing free ICD-10 training so that you are aware of some of the issues that they've run across. So find out what is available and make sure you take advantage of what they have. Another question that you should ask related to that is what are some of the costs? What are your costs of training and upgrading? And be aware of that so that you can include that in your budget, because there will be costs. Another question that you should be asking about are their trading partners, such as their clearinghouses. Are their clearinghouses ready? So the reason for this question is, when you actually submit real data, is it going to go through? In the 50-10 conversion, some of the clearinghouses and software vendors, such as EHR programs, had some issues that they weren't aware of because they weren't using real data. So be aware of that. Another question that we found from CMS just the other day, and it's not included on this slide, but you need to ask specifically how their system will handle situations where dates of service before and after October 1st, 2014. So, for example, can you handle the situation where you need to resubmit a claim which was in October of 2014, or it was before October 2014, so you should be using an ICD-9 code. So are they set up to handle situations where you've got before and after and spanning dates of service before and after that time frame, where you will still need to be able to have ICD-9 codes and ICD-10 codes? Another final question to look at is testing with the actual payers. One thing that we found in 50-10 conversion is people weren't testing real data, and their tests were standard. So make sure that you have a chance to submit your own test claims with the payers, not just with the vendor, but the payers, the clearinghouses, using that particular software package.
So how can providers budget for ICD-10 then?
Well, there are actually 4 different areas that you need to evaluate budget concerns. The first one is just the actual cost of your computer system upgrades. Will you need to upgrade hardware? Will you need to upgrade software? And look at those different costs and see what kind of contracts you may already be locked into. So you need to sit down, and that's one of the questions that we talked about, asking your vendors, see how much that will cost. That would also, the second question is the auditing and monitoring your documentation for ICD-10. What needs to happen on the part of the payers, and this will take additional costs because staff needs to do this. Staff will need to audit claims that are going out and review it against charts to make sure that you are adequately meeting ICD-10 requirements. So this will take more time as you're making this transition, preparing for the transition. In ways, you're almost going to be doubling the amount of time that you're spending right now. So be aware that those staff costs, in addition to just reviewing your records, actual editing and training, education and training should also be part of your budget. You may need to send some of your staff to training, so be aware of those costs and put that in your budget, and beware of how that's going to affect your staffing and overtime. According to a RAND Corporation study, larger providers and clinics can expect up to $40,000 on average. So that is part of their budget. Now, smaller clinics, the cost they say, will probably be closer to $4,000 or $5,000. Make sure that you have those in your budget and you're prepared before October 2014 hits. Some consultants that I have been communicating with actually recommend that providers establish a rainy day fund. Set aside a separate savings account so that you are putting aside some money now so you're ready. Be aware that there could be payment delays during that time frame. So you might have to, hold your own for a month or so while things are still getting worked out, there can be, and there will possibly and likely be delays. The same thing happened with the 50-10 implementation. So make sure you set aside the money and you're prepared and ready for that possibility.
Do any of these costs stand out in particular? I mean, obviously, upgrades to information systems aren't going to be cheap, and education and training can be expensive as well. Is there any that people need to watch out in particular that might be a surprise?
Well, one thing, as I mentioned, the 50-10, for example, anesthesiologists had not tested all of their scenarios, and in one of the reviews by CMS, there were anesthesiologists that were not paid for up to 3 months. So that was one of those gotchas that they ran into. So when you're testing and you're actually practicing, use those uncommon situations as well as your everyday ones. And that's why we were emphasizing the actual testing, real data testing, so that you can get an idea of where you might run into problems. And so if you're setting aside and if you're doing that testing, heavy testing, not just surface testing, I think you can help avoid some of those potential problems that we know have been encountered before.
So what are some critical areas where ICD-9 codes should be updated to ICD-10?
Obvious one, of course, and that's why it's on the top of the list, is your EHR and your EMR systems. Those are very, very obvious, and another obvious place is where you have your claims processing. However, there are some other places that do get overlooked. We understand software. We sometimes forget that it takes time. We've got to give ourselves time to adjust to software changes, because it's not just the codes that will be changing. A lot of times other things in the software change. So give yourself plenty of time to test and train on your new software. And be aware also is your forms. A lot of people that we've discovered as we talk to them forget about charting forms, your intake forms, other internal forms that you use. A lot of them have ICD-9 codes on them. One good thing to do is enlist the help of staff as they run across, put a sign up that says, remember, look for ICD-9 codes. And as they are passing out forms or they're using forms, make it easy for them to report what forms they're running across that contain ICD-9 codes, so that it can make sure that they get updated to ICD-10 codes. And be sure that there's plenty of time to test. So even though a new ICD-10 form would be created, they need to have a chance to use it and make sure that it works to meet their needs. Additionally, that kind of ties into documents. So some people have pre-filled ABM forms that they're using right now, for example. Those forms will need to be updated. Another gotcha area is your standardized form letters. For example, if you send out test results or other correspondence with insurance carriers or partners or other patients, you need to make sure that you look at those standardized documents and make sure that you're catching all of them. And this is where the front office is really going to need to be enlisted and be on board so that those can be updated on a as you run across them basis and not wait, so do those quickly. Another forgotten area is websites. There are several places, some practices have extensive website information. So someone will need to go through, if you have a website, make sure that where you talk about particular procedures and what is covered, not covered, or any of that kind of information, look for ICD-9 codes on your website as well. For many providers, that won't play a role, but there are some who have websites that are very comprehensive, so evaluate that as well. I touched on contracts before, and look at the contracts that you currently have with third-party payers or other partners and review them and look for changes that maybe they have missed, or pay close attention. In some cases, you may want to have legal counsel review contracts because there will be new contracts coming out. Another one is your policies and procedures manuals. And there are a lot of times that ICD-9 codes are specifically discussed on how to handle certain situations. So be sure you double check those as well as any other interdepartmental documents. If you can cover all of those, then you should be prepared.
So what are some tips then, in addition to those considerations, that people should consider when they're transitioning to ICD-10?
Well, first, learn the basics. Reviewing these notes with your entire office is a great way to help everybody understand what's happening, so everybody's aware. And then another thing that we found is helpful is dedicating a few minutes each time you have an office meeting. Those office meetings tend to cover problems or issues, but we need to also address ICD-10. So, for example, you can throw in some coding games or interesting things like that so that everybody is aware that every single meeting you're going to be talking a little bit about ICD-10. So another thing that if you look at are some of the steps. Make sure that you plan your budget. Get that done right now quickly. Be aware that there will be costs and plan for it. Then next, an easy way to look at how it's really going to impact you is do your own internal crosswalk. So look at what you are doing right now with ICD-9 codes. Pull out your most frequently used codes and do your own crosswalk of ICD-9 to ICD-10. Many software programs allow you to run statistical reports of your frequent use of ICD-9 codes or even your procedure codes. In this case, use that list and do your own crosswalk. Do your own mapping and see what those will be. The other thing is update your forms, and this is where if you have things such as super bills, people need to have enough time to look at the new one and practice with it before you go live so that they're comfortable, that they're ready, that it's not a shock and not a slow down to your system and you can keep things moving. Make sure that you contact all your vendors. This is really, really important, and that you've done your internal testing. Those facts will really, if you can do those things and take them very serious and do them carefully, then you'll be prepared. And lastly, just have fun with it and try to stay positive. I know some practices have set aside one person that's basically their ICD-10 coach or their ICD-10 cheerleader, and they delegate that part of their meetings to that one particular person to get everybody excited and do fun things like coding games at those meetings and have rewards. You know, we all like a good chocolate bar. That's a good reward for getting prepared.
So it sounds like part of it is just awareness, making sure that everyone understands that ICD-10 is on the horizon and this is, you know, something that's being implemented. And then the other piece of it is careful planning for each stage of what needs to be done to get ready.
Exactly.
So what are some of the pros of ICD-10 adoption, and then where are some of the hiccups that people have had some difficulties with it?
Well, if you look at some of these bullet points, you can kind of take them as both a pro and a con. It just depends on how things are currently working in your practice. We all know that one headache that we all face is documentation and getting the documentation done the way that it should be. The good thing about ICD-10 is that it does force us to make improvements, to be better, and to ensure that our documentation is where it should be, where we know it all should be in the first place. That's something we can be working on right now. Another is that it will actually improve data collection for studies. We do need to have better studies of which procedures have the highest rates of improvement, which ones don't. Where can we do better tests? Where can we do better studies? And ICD-10 will allow us to do that. The other reason is that it will increase our accuracy of reimbursement. Going back once again to those non-specific codes, if we can be more specific the first time around, it will be much better in being paid properly. And some of those that we know are issues, insurance payers now have the ability to fill those gaps and to issue proper reimbursement. Another is that it requires us to learn how to document better, and some people think that's a con, but I think it's a pro. We all need to be better at our documentation, and this is our chance, this is our opportunity to embrace better documentation. And another reason is that payers will be processing things incorrectly. We need to look at that beginning, at the very beginning. A con is that we may not get paid as quickly, and that's why we talked about we need to have that rainy day fund. So that can be a con, but in the long run, it will increase our reimbursement rates, I believe. Remember, procrastination just is going to make it worse. It's much better to take small steps along the way than to try and implement everything at the last minute. Documentation is one of those things that's just going to take time for improvement. If we start now on that, instead of procrastinating, then I think everyone will have a much less painful transition.
So before we get to questions and answers, and we have quite a few questions from our guests already, can you tell us a little bit about what sorts of integration tools are available to assist providers with the ICD-10 migration?
Well, the important thing that we talk about is the mapping. So looking at your ICD-9 code to your ICD-10 code. Now, there are numerous code translators, code mappers, code crosswalkers, whatever they're being called. There are many of them available. Our company does offer some of those tools to help you do that. So there are several companies, and there are several different ways, but look at those code translators. That's one of those tools that can help ease that transition. Education and training is being provided by quite a few people, from your software vendors to federal programs. CMS offers some ICD-10 training. And just be aware of all your partners and even your professional organizations, and take the time to begin that education and training. Another thing is looking at index searching. The way that some of these diagnoses are termed can be a little bit different. And this is where being able to look at indices will help, as well as using those mapping tools. Because mappings often take you to just a general area, and there actually could be a more specific or more appropriate term because there are new code groupings. And so the index can help you to see if there are new areas. So take time to look and do some index searching as well on your commonly used codes to see if there are better areas. One tool that is offered by Find a Code is a code builder. And you can start with a general section and gradually build and look for those more specific areas. So, for example, there are placeholders in ICD-10 where they've left space for new technologies or new advancements to fill in those spots. So they've left space for growing. So code builders help you see where those are taking place. Another thing that's new, and this has a lot to do with 5010, is looking up NPIs. You will need to have in your claim submission NPIs of all of your referring providers as well as the individual providers. So they're looking up those NPI numbers and being able to look those up quickly online can help speed up that process. And be aware of other tools that are being provided by your software vendors as well as other outside vendors. And there are quite a few of them available out there. So take some time, look around, and try out different ones and see which one works for your practice.
All right. Well, we already have a number of questions from our attendees. I'd certainly like to invite everyone to post their questions into the chat area, and we'll get to as many of them as time allows. After the conclusion of our session, we will send out a follow-up email that will provide a link to written answers to the questions. So the first question for you, Wyn, is someone would just like you to address indicators a little bit. I'm not sure completely what they're getting at there, but maybe that question is clearer to you than it is to me.
My first thought on the indicators is, are those some of where you have the late effects and the sequela? I'm wondering if that is what they are referring to. If that is the case, that is a new way of looking, as we talked about, changes in how we code. So when we treat, by being able to say if this is an exacerbation of a current condition, it enables a payer, a third-party payer, to see that this is a new situation. This is not treatment for a pre-existing thing, and it helps with coverage. It also helps to establish the length of treatment. So chronic conditions obviously will be treated differently and paid differently, as well as something that is a new condition or an exacerbation. So I hope that answers the question. If not, then give us some further information and we'll get that answered offline later.
That sounds good. Here's another question. Do you feel that it's important to have a backward mapping plan in place in case there are some payers who are not ready for ICD-10 codes on October 1st, 2014?
That depends on who you talk to. So it was phrased as, to me, I think that the backward plan is not as important as the forward. Those back crosswalks, I think, will be used more by payers than by clinicians. And if HIPAA is telling us that we have to use ICD-10, payers who are not compliant are the ones that need to be worried about those back crosswalks, not the individual providers. So I would be more concerned about just moving forward, the 9 to 10 and staying with 10.
All right, well, here's sort of a similar question in some respects. The question is, if the effective date of ICD-10 is October 2014, will payers accept claims with ICD-10 codes before that date so providers can do some real-world testing?
I have heard, and I have not been able to confirm this, that there are some large payers that will allow you to do real claims as part of the testing process, and they will actually pay on ICD-10 before October 1st. So that's another reason for being prepared. I have heard that that is a possibility. I have not been able to confirm it with any individual payers as to real payment versus just testing.
All right. Here's a question, and I think I know the answer, but I'm curious to hear what you say. So the question is,
Okay.
most times medical coders are responsible for coding. Does that mean that coders will need to have a more in-depth knowledge of anatomy using ICD-10?
Yes, they should have a more in-depth knowledge.
I thought that's what you were going to
However,
say. Please continue.
yes. However, even though coders should have a more in-depth knowledge, we have to keep in mind that providers, those who are doing that service, also need to do more training and be aware of those needs of documentation requirements so that it isn't left in the hands of the coders as much. So we need to make sure that clinicians have plenty of time to start their documentation, and that's why we kept focusing on documentation throughout. Now's the time to start improving documentation and seeing which codes will need to have more information and make sure that what we're getting, we eliminate as much of that as we possibly can. However, we can't eliminate it, and thus it falls into the hands of the coders to be able to understand more about anatomy. So brush up on anatomy.
All right. Here's a question about SnoMed. So if a hospital uses SnoMed for charting diagnoses, how well does that map to the new ICD-10 codes?
I know that laboratories in particular use SnoMed extensively, and from my understanding of SnoMed, I have not worked in a hospital setting very much, but SnoMed does a crosswalk back to the ICD code, and I would imagine that it will be doing the same thing on the billing end. On a lot of cases, all that they would need to do is still use the SnoMed code, and then behind the scenes, a lot of that is done internally by software. So on my end, that's a little bit of a guess because I am not involved, and I have not seen what SnoMed is doing compared to ICD-10.
And so for those of our attendees who may not be familiar with SnoMed, it's essentially a clinical diagnostic set of codes rather than more the billing set of codes that are ICD-10. Is that fair to say?
Much like, yeah, that's pretty close. It's much like in the psychiatric world, they use DSM, and that's the Diagnostic and Statistical Manual. Now, that's what they use for their diagnostic criteria, so that helps them to establish the proper code to use. So I know that the Psychiatric Association has updated their DSM manual so that it can work with ICD-10 codes. So based on how that is happening, I would say it would be safe to assume that SnoMed is in the process of doing the same thing that they are.
All right, here's a question about testing. What testing process do you recommend if the payers will not test with a provider practice?
Look at what your software will allow. When you're testing, obviously the first step is understanding any new software upgrades and making sure that your practice is getting all the information in that they need to. So you can start with what's on your end. The payers, yes, will probably end up being a problem. There are some smaller payers that, like the 50-10 conversion, will be a little bit slower. So you do the ones that are ready. Your federal programs are going to be ready. So they are testing those things now, beta testing some of those. Just be patient and do what you can internally, checking documentation, reviewing charts against the codes and the claims. So do your own testing beforehand and make sure what's coming out from your system is what you want it to be, and then test with payers as they become ready. So that's part of our initial question is check with the payers too and see what their timelines are. And if you are using clearinghouses, they'll be able to tell you who's ready and who's not. Test the ones you can first and get the bugs worked out of that one, and then go on to the smaller ones that are maybe a little slower in adopting and for preparation.
So here's a question that maybe should be addressed to CMS rather than you, or maybe the United Nations, I don't know, but could you tell us a little bit, why is the United States so far behind the other industrialized countries in adopting ICD-10? How have we gotten into this place?
Well, some of that is just simply based on the fact that we have such intricate insurance payer systems, such intricate billing systems, and we have spent a lot of time and done a lot of development, and a lot of these different payers or I don't want to get too political here. I want to try and stay politically correct.
Sure.
But there was a lot of lobbying for it to not happen. And so it actually took an act of Congress, literally, to force everyone to make the change. So that is why we are so slow. And, you know, we haven't passed a federal budget right now, so we can see that it takes a while to get an act of Congress through.
Right. So it's a big, complex system, and not everyone was enthusiastic about moving ahead, is at least part of it.
Yes.
Here's another question.
They had many people that actually wanted to jump to an entirely different system. So it's just trying to get everybody on board with our very, very large, independent payment systems.
Sure. So how much is the judgment and the expertise of the coder or the provider a factor in ICD-10? Because, you know, in some cases it sounds like it maps in a pretty direct way, and in some cases it sounds like it really requires some judgment from the person doing the coding. Can you tell us a little bit more about that?
There will be some judgment calls that will need to be made. And this is where it's really important that you sit down beforehand and look at your super bill, your charge sheet. Pull it out, do your own internal crosswalk, and as you are doing those crosswalks and as you're looking at the mappings, have the providers looking at those as well. Those clinicians need to look at it and say, okay, this is what I really mean by this. And you can, at that point, narrow down some of those and reduce some of the need for judgment calls. So that is why we encourage that particular step. And if you have the payers involved on those that require some more clinical decision, do some training where the payers will say, this is what I mean, and if I say this, then this is what this will mean. So create your own little cheat sheets so that you are more prepared. And always, if there is any question, it's always best to ask the clinician. And I know that's hard sometimes, and I worked for a very, very busy internist, so sometimes I would have to stack a few papers back on his desk and say, did you mean this or this? And that's where the study in anatomy will come in handy. The more you know about anatomy, the fewer questions that we will have to pose to the clinicians on an after-the-fact basis.
All right. Well, I know that you're not an attorney, but there's a question about contracts, and so address this to the extent that you can. But should contracts contain specific language about ICD-10 adoption? I mean, does it need to get into the nitty-gritty in that? You said you should review contracts, but should they specify what's expected around ICD-10?
Well, the reason why I brought that up is because there was one very large payer who recently, like last year, sent out new contracts. And in those contracts, it stated they were supposed to be using ICD-10 codes. Well, we had a lot of panicked providers calling us saying, wait. We have to use ICD-10 codes. So you need to look at the language specifically in the contract and make sure that you see when they will be requiring the use of ICD-10 codes. And if the contract isn't clear about that implementation, that's where you need to make sure you go back to the payer and say, this is not clear. And so anything beyond that, where you have questions as you're looking at it, that's where it would be helpful. If you have a question, consult an attorney. I'm not an attorney. I just brought that up because I noticed specifically ICD-10 coming up in contracts, and we had some very concerned clients.
So we still have some other questions. We're starting to run out of time. I'm going to save the last question for myself because I'm just curious. I've heard this awful rumor that there's this thing called ICD-11. You know, it's a little off our topic today, but I just wonder if you could address, ICD-11 is on the horizon. When is that something that's going to be part of our lives? Or do we know?
Yeah, I knew that this question would come up. Yes, I do know what's going on with ICD-11. Who is planning on releasing ICD-11 in 2015? Now remember, ICD-10 is not the same as ICD-10 CM, the clinical modification. So what will happen is they'll release their ICD-11, but CMS has said that they wouldn't be able to implement any of that until at least 2020. A clinical modification would need to be made in order to work with the systems that we currently have in place in the U.S. So saying that you will jump to ICD-11 in 2015 is not entirely accurate. Just ICD-11 itself will be available, but it's not going to be ready or clinically modified, be available for use for quite some time after that.
So the process it'll initiate in 2015, but that's the beginning of a long journey toward ICD-11 implementation.
Yes, it is. It's just the start of the whole process. Another consideration, if anyone has taken a look at ICD-11, they have some, just like whenever there's any code changes, you have your beta testing. It is actually more database centered. It is a different way. It's different than ICD-10. So those who are used to and really prefer opening up a book to look at a book, it's going to be harder for them to do that. By going to ICD-10, it gets them used to some of those tools of code builders and mapping and more software database orientation. That leads the way to the implementation of ICD-11. So it's a huge, huge jump. It would be a monumental jump to go from 9 to 11. Instead of, let's take the interim step, do 10, and make sure that we have time to fully prepare and implement 11.
Well, thankfully, people don't have to worry about 11 quite yet. I think we've all learned a great deal about ICD-10 implementation today. I'd like to thank you, Wyn, for joining us for today's Learning Lunch.
Thank you for having me.
I want to remind our attendees that we're going to assemble all of the audience questions and post the answers on our website with links delivered via email later in the week. I'd like to thank all of our attendees for joining us today. Again, you'll receive an email with links to both recorded and PDF versions of this session. Be sure to join us at ForMed Approved for our next Learning Lunch, which will air May 7th. That Learning Lunch's topic is Understanding the HIPAA Risk Analysis. Keep an eye on your email box on our homepage for other upcoming topics. We have a busy slate of Learning Lunches for May. Thank you again for joining us today, and thank you in particular, Wyn, for sharing your expertise with us.
Glad to be of help, and people can come to our website and get some more help.
All right. Thank you.
Thank you.